So originally this was called psychological neglect. Are you not online? Are you not present for your kids? Then the next thing that was discovered is actually a lot of not a psychological neglect is parental disattunement. And you've probably done that if you've had kids, or you were a victim of that when you were a kid, which is your parent doesn't always do what you need. They don't soothe you when you need it. Because they're clueless, because they didn't get good background when they were little of being soothed, or they're distracted, or they're angry, or other kinds of things. But then there's been these, I just want to drift through it, but there've been now 3 major longitudinal studies in the world where they study kids prior to the onset of birth, high-risk mothers, and follow them all the way into young adulthood, and they measured and studied them constantly. The major group of that I was involved with a little bit, I would tease them that they'd created a new syndrome in their study people, which is probably called something like Clipboard Phobia. You know, that these kids are being studied constantly. You know, they probably saw a clipboard and started screaming. But what do the groups generally find, especially the Egeland-Sroufe-Carlson group, which is the Minnesota group, the best group for the best outcome stuff? They found that although everything isn't good for having problems later on, the biggest thing was what they found to be psychologically unavailable caretaking. So these were not parents who were being mean to their kids. They were just not there for them. So this does bring us to interesting places, because it means, how do you actually hurt kids? Well, you can hurt kids by actually hurting them, so that they're encoding memories of being raped or beat up or set fire to, or all the lovely things that we see happens to kids sometimes. But what is the big frihole? What's the big deal for little baby people? What would the Egeland-Sroufe Minnesota data say is the thing? If you want to take care of a kid, what's the thing you have to do the most? Be attuned to them, be responsive to them, reactive to them, positively regarding of them, viewing them as not extensions of yourself, which is a risk, but instead as beings that you want to facilitate their independent development in the context of loving, caring stuff. Pretty hard psychological task, especially parents are very stressed, so how are they going to be able to do that very well? Luckily, per the British object relationships, you just have to be good enough, right? You have to be a good enough parent. You don't have to be an excellent parent. But what we're now knowing, this is the stuff that Linehan in DBT talks about, is people expected all borderlines to have sexual abuse histories, and a lot of them appear not to, but they do come from very marginalizing, devaluing childhoods. So Linehan was one of the first people to say, you don't have to have sexual abuse for these kinds of problems. You can have just that you weren't loved, you weren't attuned to enough as a kid. Well, so what? Shouldn't that just make you be, you know, kind of bummed? What's the problem here? The problem has to do with child development. And, you know, we could go on like this forever, but it looks like the first 3 to 5 years of life, we have, if our neurobiology and our psychology comes on appropriately, if the cascade of unfolding events in our neurobiology and our attachment and our psychological development and our skills development and our internalization of working models of what's real in the world, for all that stuff to happen in the first 3 to 5 to 7 years of life, we have to be treated well. So we have to not be distracted by painful things that both keep us from listening and paying attention, and also cause us to close down when we need to learn things. But we also need to be in benign, supportive, caring environments that support autonomy, but also nurturance that allow us not to feel bad. Because, and this is the part where I can go on too long, so let me just say very briefly, this is the interface between sort of evolutionary psychology, early attachment theory, and trauma. But basically, the bottom line for humans is that we need about, we don't really know the answer, about 5, 7, 9 years of supervision from birth on to not die. So in the evolution world, they talk about this as protections against predation, starvation, and exposure. So that if you're a little baby being of the type that we are, especially mammals, when you're born, you'll just die. There's 3 ways you can die. The weather can get you, something can eat you, or exposure, predation, and starvation. Someone would not give you food. So we had to evolve something, not just humans, but the higher chordates had to evolve a system where our biology reinforces connection between parent figures and little tiny figures so that both will stay together long enough for the parent or caretaker to keep the kid alive for 3 to 5 to 7 years of life. So what we've evolved is all this biology that reinforces connection. And that's all the lovey-dovey schmovey stuff. So when you fall in love with your little kid, it's adorable and it's very fancy, but interestingly, on some level, what's happened is that your body is activating neurochemistry that supports attachment, that supports you cuddling and nurturing your kid. And if your kid's cuddled and nurtured and protected and fed and safe from the elements, they're going to be able to keep the species going. Turns out it's in both the kid and the parent. Both parents and kids have the ability to seek out attachment and to feel rewarded by attachment. And what is the reward for attachment? It's the love stuff. It's the effects of endorphins and oxytocin and dopamine and certain of the more activating associated neurochemicals. There's a lot of stuff there. You know, do you remember that movie Love and Other Drugs? I didn't actually see it, but it was a hell of a title, because that's what we're actually talking about, is that we are drugged when we're in love. Have you ever noticed that when you're really in love, you'll feel like you're organic, you know, and you're laughing for you look high, you know? Well, I'd suggest you are. That's not all there is to love and connection, etc. And why am I bringing this up? Because the problem for baby humans is if we're wired to need love, and so that we have connection, so that we have safety, we're also wired to feel pain if we don't have love. So abandonment, rejection, disattunement is actually painful to us. Why do we evolve the ability to feel bad when we're being separated? Evolution doesn't care if you're happy or all, it just wants you to spawn progeny. Right? So basically, if you go, oh my God, nobody's here, evolution wants you to feel horrible, because what? It wants you to reattach, fix the injury, try to repair the disruption by reconnecting. So what this means is that probably early neglected, rejected, disattuned kids are in great emotional distress. And all you have to do is look at like the Bowlby film of the abandonment cry. I worked in a pediatric transplant program at Loma Linda as a consultant for a while. Those little kids were way more worried about the parents being around than all the machinery in their bodies, or so it appeared to me. The loud cries were when mommy was going away or daddy was going away. So they're very important stuff for us. So what that means is that Linehan was right about it doesn't have to be just sexual abuse. Really what this comes down to is if your early childhood hurt an awful lot, you're in trouble. But it can hurt an awful lot because people are doing acts of commission to you, or because they're not giving you what you need, and that's activating your neurobiology to produce great distressing feelings. Now this is just a very, very schematic here. But is that the end of the story? I've given you a hint. If you feel really bad when you're little, does that mean you're going to cut on yourself when you grow up? Well, we now know that the likelihood has gone up. But we need two more variables, and especially one more variable. We need a mediating variable here. It's attachment. So attachment is the dance between the parent and the child that allows the parent to teach the child things. Child gets to infer their goodness by the fact they're being treated well. They're learning how to be a human with other beings. So attachment, you really got to have. So if you look at very modern structural cohesion models where they look at abuse, they don't normally anymore go abuse to symptoms. Usually they do abuse to attachment to symptoms. And what you find is that abuse produces symptoms, but the biggest pathway is that abuse screws up attachment, and screwed up attachment produces symptoms. So part of what we think here is that the person who has to cut is not only one who's carrying around painful memories, which will matter in a minute, but they also have insufficient grounding, stabilization, soothing, supportive, organizational, mentation-focused processes. And so they are basically on some level cast adrift without a sense of self, without as much of a completely functioning being as someone who's been loved and taken care of. Have you seen this? If you see two kids, one kid comes from a loving environment, and when something happens in their environment, they don't get very freaked out. They're almost like, oh, this sounds interesting. What's happening? I mean, Don't you hate those people? They had such a happy life that when they see something potentially dangerous, you know, they go, oh, wow. You know, like if there's a person in the back of the room there and they're coming towards me, and then there's a person here who had a great life with perfect attachment experiences, right? They're going to look up and see that person over there and say, hark, who goes there? My gum, I'll bet that's a friend I have yet to make. So they're delusional. They're delusional because they have a life system that's told them that people are there to help you. I actually technically call that pronoia. Pronoia is the delusional belief that people are out to help you. But what's going to happen with me, especially in my earlier years? Someone is in the back of the room and I go, warning, incoming sectors 5 through 9, armamentarium up, fire at will. But we both saw the same person, right? So this is going to matter when we talk about triggering and other kinds of things. But the problem for the people with bad attachment experiences is we are going to generalize those early experiences to our current experiences. So we can get devastated by perceived rejection. Because it's still alive, that early stuff is still alive. That will also increase the likelihood we will cut ourselves, but that's called increasing reactivity, right? That our threshold, if I look at you and I go, Susan, you know, don't bother me today. You're a good person, but I got work to do. Okay, can we just talk tomorrow? Well, if I did this in this room, there'd be like 3 groups of people. The first group of Susans who came from a great life, they go, okay, John, bye. The second group of Susans who had a relatively challenging life say, what am I, chopped liver? You're really an asshole. I may even turn you in. And what does the third group do? What I like to call my people. They might attack me. They all saw the same thing, but their reaction to it was different. So in both Buddhism or mindfulness and in psychology, we call this decreasing reactivity. If you take it less seriously, you're going to have a less reactive response. But then there's a third thing, which is that attachment disturbance screws up something else. So we have adversity, which is encoded in memory, which affects attachment. If attachment is affected, it will have negative problems too. The biggest problem we have here, and we have to introduce a term now, is emotional regulation capacity, or affective regulation, if you like, or affect regulation. People do different words. Basically, everybody in this room could be characterized by your relative ability to calm yourself down when you get upset. Now, you're probably not all good at all sorts of upset. Probably some of you are really good at anger, but not at fear. You know, it could be a bunch of different things, but we would say that early on in life, if you had a good attachment history and there was no biological things that got in the way, that you will probably be able to respond to things without having massive reactive functions. But if you were hurt a lot when you were young, you're going to be blown into these states, and when you're blown into these states, you won't really be in control of your behavior anymore. So if you've ever gotten really triggered and you're really furious about something, there's a little part in the back of your brain saying, that, come on now, man, you're way out of control, right? Have you ever had that experience? You know, the part of you that's driving the bus is infuriated. The part of you that's worried you're going to be arrested or lose your friend is back there going, yeah, but because you have so much reactivity, you can't get anywhere. It turns out, though, that in the process of the attachment development systems, which is 0 to whatever, and I'm not being cute about that. Different people say the high end of attachment is different ages, but it's when you're relatively little. It's in that phase that you learn emotional regulation. So if your attachment is dysregulated by neglect or omission or commission, and you're highly reactive, and this stuff means that you don't have a good attachment experience. You have an insecure attachment experience, fearful attachment experience. What that means is you will be deprived of the opportunity to learn how to downregulate distress. This is important, and I need to move on, but I do want to make this point. We often think that the most challenged people we see have acts of commission as an explanation for their behavior, like sexual abuse or physical abuse. And that's right, because those things are very, very bad for you. But when you look at the extreme behaviors like self-injurious behaviors and things like that, or reactive behaviors, usually we need even more than that. Basically, you have the pain, but you're missing the regulator, the thing that would keep it in control. The regulator are attachment experiences, and associated with that, your emotional regulation skills. So we built a whole model here. So if we now look at this slide, we would say, early in life, you have had a lot of trauma. We know that interpersonal trauma hurts you more than others. So if your early trauma was you were moved from one area to another, but people were nice to you, that's not as bad as if your father left you or your mother did or someone beat you up. If you were in a flood in New Orleans, it's not going to be as bad as if someone rapes you in New Orleans after the flood. So it's interpersonal for a variety of reasons is going to hit us deeper than non-interpersonal. So early trauma, early child abuse, and neglect, we sometimes call that maltreatment. We've talked about that so far. That would produce attachment disturbance, and the attachment disturbance would lead to low levels of emotional regulation. Now, already we're talking about us in this room. So, would you agree that you don't have to be critical of someone who's in this jam? This is the predicament, which is you didn't choose to be neglected, didn't choose to be abused, you didn't choose to have attachment dysregulation, you didn't choose to have an attachment style that interfered with your ability to regulate states. So then when now you punch someone out because they said something mean to you, is it really your fault? And I'm being a little provocative here. You all have your own views on that. But can you see how you might move into a Buddhist or a dependent origination model and say, maybe that's not actually your fault. Maybe you're in a jam. Or if it's your fault, maybe if we can't go that far, maybe you could say it's not entirely your fault. So to what extent can you do something else? Well, if it's out of your control and it's not really your fault, the only way you're going to get better is if you interact with someone who can help you. Because now you have new determinism. You have that there are beings out there like you guys who have a skill set that can interact with people like that. And then now their determinism has changed, right? Now when they get activated, they have opportunities they can do to calm down, etc. So the idea is that we are empowering people to be able to take control over their own life experiences by us providing new data, us doing new things. In the meditation world, of which I'm fairly ensconced, and I've been asked to speak on this in several conferences, people say, can you meditate yourself out of psychological difficulties? Well, it's not as, maybe some can. If you can develop mindfulness, and mindfulness teaches you to relate to your intrusive thinking differently, maybe it could help you. But generally what we say is, no, you need a therapeutic relationship. You need another person to activate you and respond to you and interact with you. And that's what we'll be talking about today. So what you're the next part in this, which is when people come with those problems, how can you help them? But if you think you're a physician or you think you're a car mechanic, you're going to try to find the thing that will cure them. But what we're going to be doing today is what we really want to do is find the things that will empower them and give them opportunities to do other things than what they're doing that are getting them into trouble. Basically, if you have a client who's cutting themselves, I have no way of knowing how to make your client stop that. But we might work together so that the client has less of a need to engage in that behavior. And since most people don't want to cut on themselves or have sex with strangers or other kinds of things, once they don't have to do that, they probably won't do that. But apropos what I said earlier, you could have someone who's not, you worked with them, they don't cut on themselves anymore, and they come back to you 20 years later and they're cutting on themselves again. That's not because you failed before. Remember that no memories are actually wiped out, they're just inhibited by later memories? Well, maybe you were abused again later and it's activated your early thing. That's part of what we call reciprocal memory theory, which is sometimes old memories come back if they're reinforced by new bad things happen to you, or maybe something has changed in your life. Typically what we find is if people were using if they were using self-injury and then they stop and they start again, typically they only do it for a little while because they're probably just destabilized by some current event and then they can stop doing it. The danger is when it's something like dementia, or severe permanent role change where nothing is going to change, then you might stay in those states for longer periods of time. So what this then comes down to is that any DRB, but certainly this one, any DRB is going to involve an imbalance between the amount of pain you're carrying around from your abuse and your neglect and your ability to handle that pain, which is your emotional regulation skills. So in modern work, at least the work of ITCTA, but also in some of the other work that some of us are doing, we say that all of us in this room are an accident waiting to happen on one level, which is that all of you have some stuff that would really freak you out right now if it was triggered. If you were suddenly reminded of a sexual abuse experience, or you suddenly saw a loved one hit by a car, or whatever it might be, that in those circumstances, what we need in order to get in trouble in DRBs and cut on ourselves is that we had lots of pain that was triggered into a negative state. So trigger will be important today. You don't just have a bad day and start cutting on yourself. What happens, you cut on yourself after you've been triggered into painful memories of the past. We'll cover that more in detail soon. So when you do get triggered in those circumstances, we still don't know if you're going to cut on yourself. So any of you have been in therapy for a long time, you may notice that you'll still get triggered. It just won't freak you out. The triggers aren't really gone. I'd love to talk to you more about this. I've tried to write about this. But if you look at modern theory, those memories are still in there. They've just lost their probability of emerging in full form. So if I believe, for instance, I came from a very difficult childhood with all kinds of things that have made me the neurotic piece of traumatized person you're seeing to this day. Those, except of course, psychoanalysis and meditation has fixed all those things. So I'm actually fully evolved now. And you may probably say, I want to be like John because he seems so cool, right? I mean, but the reality is that we're all walking around with some of that stuff. What we want to think is that if we get good therapy, we won't get triggered anymore. And we won't have memories come up. That's your brain's your brain. It's going to do what it's going to do. What's the problem? The problem is not whether you get activated in the state. It's what? It's what you do with that state. And what you do with that state is going to have to do with your neurobiology, and it's going to have to do with the number of skills you developed to allow yourself to bring down emotional distress. So you could, let's say it's improbable. You had a kid who was sexually abused, physically abused, ignored, denied, unloved, had bad attachment experiences, interfered with the development of emotional regulation skills, and then they get triggered big time. Are they going to cut on themselves? Maybe, but what is the big moderator there? What's the big mediator, depending on how you look at it? It's, do you have a way to deal with your activated states? And that's what we're going to be all about today. It's going to be very concrete. If you do get triggered, are there things you could do to keep the trigger emotional states from motivating cutting on yourself or punching someone or having sex with a stranger? Because ultimately what we are saying here is that DRBs, including self-injury, are adaptive coping responses when your pain exceeds your ability to handle pain. But if you have them, I mean, sure, have you thought about this, that maybe you feel you're doing better now in your life than 6 months ago or 4 years ago? If you said to yourself, oh man, if this had happened to me a year ago, I'd be so freaked out right now. What a lovely thing you can say to yourself. But you know what's interesting is the past never goes. It's never not. The past is still the present in some ways. It's alive. It's just that there's learning since then, you know. So you could still get pushed into being upset, but the upsetness can't go anywhere because it's being inhibited. Okay.
Question.
Yes.
The etiology has overlap with substance. And so are you aware if there has been any research conducted as to how a person either chooses self-injurious behaviors compared to substance?
So he's asking, since these behaviors would seemingly, so this stuff about reactive avoidance is what we call all these strategies, whether it's cutting or drugs or dissociation. But the behaviors we're talking about here are called distress reduction behavior in particular. He's saying, well, what if you're high trauma, low emotional regulation, maybe cortical problems. Some people have brain issues. They can't inhibit things so much. What determines why some people uses alcohol and another person cuts? Or we could just say within DRBs, why does one person cut and the other one sexes and the other one binges and the other one does trichotillomania, pulling hairs out of their head? We don't really know the answer to that. I mean, I think we're struggling with it. I could say things, but we don't really know about that. We know that that's a very fruitful. We do know that substance abuse and DRB is not the same thing, though. So cutting on yourself and drinking too much are related, but enough different that we usually have to approach them differently. That's why ITCTA has a substance abuse manual and it has a distress reduction behaviors manual. So we're going to break just in a few minutes, but let's look at this functions thing, because this functions will tell us things about where we want to go from here, which is if cutting on yourself does stuff to help you, what does it do? And then could we find ways to find other things that would do those things that wouldn't involve cutting on yourself? So we'll just go through them very briefly here. People who cut on themselves often do it because it distracts them from emotional pain. That might seem unlikely to you, yet that's the central finding of all studies that have asked self-injurious people why they self-injurious, which is that physical pain neutralizes emotional pain. And emotional pain hurts worse, but if you can distract yourself by feeling physical pain, that it takes away attention from emotional pain. I think the abuse survivors in the room know this, don't you? Which is, as bad as physical pain is, emotional pain is the worst thing. And that it tends to be less regulatable, and it tends to be easily exacerbatable, and you can perseverate on it, ruminate on it, etc. So distraction. Externalization is some survivors say they cut themselves because they want to take it out of inside and put it on the outside of their body. Some say that they're trying to communicate distress. So that might be my client is smearing blood on her blouse in the waiting room. But for some kids, it's just literally help me. It's a cry of distress. Proximity seeking. Some people, remember people that haven't had good attachment experiences, they probably don't feel loved, nurtured, supported. So some people have discovered that if you cut on yourself, people will pay attention to you more. Sometimes people who go into physicians because they have not anything really wrong with them, I believe it's a fancy version of this. You know, this problem, people come in, they really just need to be with a benign person who says, there, I understand, I'm on your side. You have a problem, we'll fix it, even if it can't be fixed. So that would be proximity seeking too. This bleeds out a little bit then into when we're looking at medical psychology and trying to figure out what do we do with a worried well they keep seeing clinicians. I think sometimes they're trying to find relatedness because they haven't had the kinds of things we've described so far. Relief from dissociation and numbing, we'll talk about this a tiny bit later, but it turns out that sometimes when people have been traumatized, they shut down as a way to deal with being traumatized. But if we're shut down, that feels very bad. People come into emergency rooms with reports of feeling shut down. So the danger is you could be using avoidance, whether it's numbing or dissociation, to shut down your pain, but you could do such a good job that you're now suffering from being shut down. That's why when some people cut, they say, I cut myself to see if I'm alive. Who needs to know that? Someone who's already dissociated. So what will happen is that we have a double whammy here. You may use dissociation to problem solve overwhelming pain, but then you may use cutting to problem solve overwhelming numbing and dissociation. I know it's a little fancy. You can read the paper by Aaron, Edie, and myself. It's downloadable from my website, johnbriere.com, where we actually looked at that and were able to find that it's actually for many substance abusers, for many self-injurious behavior people, is the presence of dissociation or numbing is what really ramped up the likelihood of self-injurious behaviors. Do you get how it's a double whammy? You're neutralizing pain, but feeling not good doesn't feel good. Feeling dull doesn't feel good. So you then have to do something painful. Why? To try to wake yourself up from the numbing thing. What's your dilemma? You're using pain to try to wake yourself up from deadness from pain. But if you're really good at deadness from pain, pain won't work. So I'm just telling you, in your work, you may have a client who tells you that when they cut on themselves, it doesn't actually help because they don't feel the pain. That's because they're so deadened or dissociated. What are you going to do if cutting on your arm doesn't have enough pain to wake you up from your dissociation? You're going to cut other places and you're going to cut deeper places. So when we see a rapid migration to deep cuts and when we see it migrate to areas where there's high neural sensitivity like nipples and penises and other areas of the body, fingertips that involve a lot of physical pain, we could get all psychoanalytic about why you're cutting your genitalia, but actually genitalia have huge amounts of nerve input. So sometimes what we just want to do is find out, are they just upping the ante? Are they trying to find places to hurt them? But it's not just that you would cut in more places, you would probably cut more and deeper. And so that's why sometimes when we see clients who are getting heavily into self-injury, we're going to want to look to see if they are especially dissociators. Self-punishment to reduce shame or guilt. This is different than saying you have an introjected bad object you're trying to kill inside of yourself if you have that kind of psychology training. What this means is that if you feel bad about, many trauma survivors feel guilty about what's done to them. What do we do when we feel guilty? Well, the fastest thing we can do is we can punish ourselves until we don't feel guilty anymore, right? I mean, my original religion, Catholicism, that's a basic premise, right? If you've done something wrong, then you seek penance. You do things to hurt yourself, and then you can go and sin no more. Ha ha. So basically, you've been absolved of your sins by an official person who can do that. But a big part of it is once you've been punished, then you're not guilty anymore. So that dynamic, which is a psychological dynamic, means for a lot of our clients who are feeling horrible about what they've done, even though their horribleness is about having been sexually abused or whatever it is, they may cut on themselves because they're actually trying to hurt themselves. It's still a distress reduction behavior. It's this, that the goal of the behavior is to stop very specific affects, which are guilt and shame. And then lastly, and then we'll take our break, people who, a lot of the people we see are feeling relatively low self-control. And because they feel like they're being triggered and they're being pushed into things and they're being activated and they can't stop their DRBs, et cetera, ironically, although being stuck in doing a lot of DRBs can make you feel out of control, it's seriously got to be we've actually done this stuff, but it must be number 3 or 4 in the hierarchy of what people list as why they cut on themselves, because they want to at least feel some control over something, that they cut themselves and they can feel the pain. Well, could we help people if we know these things? Well, we're going to take our break, but could we do something about the emotional pain so you don't have to distract yourself from it? Could we find better ways for you to displace your pain than to cut on yourself? Like, could you tell a story? Could you write a book? How many novelists out there are actually just trying to externalize their trauma? Could you communicate your distress better than cutting on yourself? Could you find a way to connect to people? Could you increase your emotional skills so that you'd have more emotional intelligence and you can hang out with people? So all the lonely people, where do they all come from? You know, right now, what's the most lonely group of demographic in the United States right now? Just came out yesterday. It's college students. Who would have thought that? In their first 2 years of university. It just points out to us it's not necessarily the street person that's feeling lonely. We are a culture that's isolating ourselves and making us stare at little screens and having sexual interactions facilitated through pornography rather than people. We're cutting out everybody. So this, I think, you pay a price for isolating yourself from other people because we're highly social beings. So we're actually working against ourselves. Could you find ways to deal with dissociation and numbing? Yes, you can. So that'll be cool. It's so that you wouldn't have to use self-injury. Could you forgive yourself, accept yourself, revisit your shame and guilt so that you can see it's not really your fault, so that you don't have to hurt yourself for feeling that? And most importantly, could you feel more control over your person without having to stab yourself in the arm? Are there other ways to feel greater control? So we're doing something fancier than that here today, but do you see that the basic premise here is there's no pathologizing here, is there? It's saying this is the psychophysics of life. The psychophysics of life is a lot of us are going to be hurt because that's how it is, and we know that. That's going to affect our child development, which is going to affect our ability to regulate distress. We're going to walk around later easily triggered into those painful memories in the relative absence of ways to handle those memories. So we're going to engage in behaviors that problem solve those things, but have big downsides. So none of that means you're sick or pathological. It means you're in a jam. And by the way, you're all doing DRBs, right? You say, oh, I don't binge and purge, but do you say, everybody hates me, nobody loves me, but there's a piece of cheesecake in the refrigerator? Have you ever chewed on your knuckles when you're scared? Have you ever run to a sex partner not because you want to spawn progeny or increase the power of the relationship, but because you want to feel good about yourself or connected? Have you ever, you know, anything you can see in any kind of DRB that's out there, there's a version of it we're all doing. But the deal is, because many of us don't have this big imbalance between the amount of pain we have and our capacity to handle pain, we don't have to make big deals with the devil. We can make small ones like Chardonnay instead of heroin. See what I'm saying? So everybody in this room and all the people you see are all bozos on the same bus. The only difference is some of us in this room, our lives have given us bigger demons. And so we need bigger ways to deal with the devil than people in this room who have smaller demons. If you just tend to feel a little bit lonely, maybe you masturbate a little bit more with fantasies that people love you. I don't know, you know, whatever it is. If you need to soothe yourself with food, but you're just soothing yourself a little bit and you're not massively compromised by what all you're eating and maybe purging is doing, you probably can dodge the bullet. That doesn't mean you're happy though, right? It just means you look sort of okay. So we like to think of this stuff as A, not pathological, and B, existing on a continuum with all of us in this room on the continuum. If you looked in this room, there are a couple of you that are bingers and purgers. We don't like to call it bulimia so much anymore. We could talk about that later if you want, but it's a different workshop. But who are involved in binging or purging. There's some of you who had sex in ways that probably didn't have to do with sex, but had to do with distraction or making yourself feel better. Maybe some of you punched someone that you really shouldn't have punched, or you screamed at someone when you really shouldn't have screamed, not because you're a psycho crazy person, but because that was a distress reduction behavior. All right, do we have any questions right this moment before we take our break? We're a tiny bit behind, but I'll catch us up. Yes?
Quick question. Earlier you said self-injurious behaviors are autonomous. Can you explain a little bit about what you meant by that?
I have no memory of having said that.
Okay. Maybe I took different pieces.
No, I probably just blew it. So I said that self-injurious behavior was autonomous?
I wrote that down.
Yeah. I don't know. Maybe it'll become clear later. Any other questions? That's probably my fault, not yours. All right. So let's take a break from now until, can we make a 20-minute break? Would you guys be okay with that instead of a 30? Yeah. I think there's enough bathrooms and stuff around for that. All right. Let's do, so come back at 11. I'd rather get the smaller Advils and just dose it up to whatever I want.
Hi, everybody. Welcome back. I just want to make an announcement about the parking situation for those of you who park here. When you sign out, Carrie Ann's going to give you a sticker to put on the little card that they gave you. And you have two choices. If you want to pay at the automated pay station at the end, you can use a credit card only. If you want to pay cash, you can go to the front desk and pay there. But make sure to sign out and get your sticker. Otherwise, they'll charge you $25 instead of $18. Okay.
Welcome back. So we have a couple of questions from our cyber attendees, and I'm just going to try to go through them quickly. Has the frequency of DRBs changed over time, with different generations? If so, why? Apparently. It looks like self-injury is more popular now than it's ever been. Again, though, this may be a contagion effect, which is kids now know about self-injury, but remember what I'm saying at least about contagion, which is it'll really only work for the kids for whom it helps in the short term. So basically kids now knowing that you can cut on yourself has allowed a lot of kids who never would have cut on themselves to find a solution to the pain they carry that exceeds their capacity to handle pain. Also, some DRBs just lose social credence relative to others. So some things are just less common or more common, and they will wax and wane over time. So there is a social component to that. How do you work with caregivers, parents of adolescents who are engaging in these behaviors? The spectrum of those that respond by getting angry and punishing, and those that feel helpless and make the adolescent feel guilty. Okay, so this actually relates to some of my guilt, which is that the model that I've developed is pretty much just a patient or client focused intervention. It's not with families, and that's erroneous. So what I'm offering you is the quickest way you can get some stuff done, but I don't think anyone would disagree that the most effective way would be to do a lot of psychoeducation with parents so they understand what we're talking about here, that it's not bad behavior, it's not sick behavior, it actually has a function, so that they can work with the kid to find alternatives to what they would normally do. And you know, what we find, and it's in the book and in other places, is that a lot of DRBs increase shame. They reduce lots of distress, but they increase shame because you're embarrassed that you're binging and purging. Well, if you have parents who shame or guilt, they can make that much, much worse. they can take over the therapy and sort of say, you know, but your therapist said, whenever you do this, you must do that. And then now the kid's stuck in sort of an authoritarian loop that isn't the loop that you wanted to provide as a clinician. So I like the question. I do think right now, Guilford, the author, the publisher of the book on this topic, is having me write one for our clients. But I think the next one might be to how to do this in families and in couples, because I think it is very helpful. And then would psychological unavailability include the model of permissive parenting through adolescence, or is attunement restricted to early attachment? Permissive parenting has to be very carefully figured out in terms of whether it's bad or it's not bad. So even of that, we're probably talking about a multidimensional phenomenon. If you're permissive parenting because you trust your kid and you understand the parameters of what they can and can't do, you reinforce to them that there's good things about figuring out what you can handle and what you can't, and giving you a chance to fall off your bike rather than making sure you never fall off your bike, those kinds of things. I think permissive parenting is probably a positive thing. However, permissive parenting sometimes is just a projection of the parents' attachment difficulties, and they don't know how to parent, so they allow anything. Or they may come from environments where they were so restricted and treated strictly when they were little that they vowed they would never do to their kids what were done to them. Those last two styles, the problem is you're now relating to your kid based on your own injury. And the odds are that's going to screw things up. That's a very basic part of attachment theory when we talk about parents whose own attachment problems are unresolved, and then it gets visited upon the kids because they confuse the kids' attachment issues with their own. So permissive parenting doesn't bother me per se, but there's no question that what looks like permissive could be disengaged. Do you hear the difference? And permissive that says, sure, go ahead, run across that street, that's fine, to a 5-year-old. They may be trying to increase the 5-year-old's sense of self-efficacy, but they're not providing adequate supervision, which is another part of taking care of kids. So we got all those variables. Having said all of that, I do think the writer was noticing that even if that were to be wrong, usually what we're talking about is a parental unavailability. If it's activating the kind of emotional distress that when triggered produces responses like cutting, that's probably pretty early stuff. So if you have a helicopter parent when you're 2, that would probably be different than if you had them when they were 11. Okay, probably earlier stuff might be potentially more problematic. But we are in a weird world right now where if you're very loving, if your kid, look at the thing about if your kid cries. All over the world, there's 2 reviews. If your kid's crying in their bedroom, what do? Half the world says what? Go in there and snuggle them and talk to them. What do the other half say? Let them cry, ignore them. How diametrically opposed can we be about a behavior, right? My view from attachment perspective, as well as other views, I think you pick them up. I don't think the crying is because being picked up is reinforcing crying. I think it's more complicated than that. There might be a little of that, but there's nothing wrong with being permissive, loving, caring. A little over-involved won't kill anyone. It's when we're over-involved because of our own issues, those issues are going to actually end up producing detachment and disengagement because the client isn't interacting with a parent figure who's concerned about them. Ironically, the client's interacting with the parents who's projecting onto the kid, and that's not going to be a good fit. So that's going to be disengagement. Does that make sense? Okay. Do you feel 12-step models are an appropriate model utilizing meditation, spirituality, and cognitive tools to combat SIB in combination with individual therapy? I have no problem with 12-step programs, but it depends on the 12-step program. So there's some out there that I wouldn't refer my worst friend's enemy to because they're high into amends. Some of them even, sometimes you'll get groups that don't have very good internal control. So although they don't smoke anymore, they hit on all the women members of the group, or they don't drink, but they do smoke. 12-step programs themselves have a lot of benefits, and I think they can be very good. Don't confuse yourself, though, with the idea that 12-step programs are more efficacious than current other psychologically developed models. You know what? 12-step works for people for whom 12-step works. And other models work for people for whom that works. I have no problem with 12-step, but I get nervous when the amends portion comes up in terms of how it's played out for some people. So I've seen survivors that have to go around and make amends to their perpetrators. And that's not how it's framed, but that's what it actually is. And I do think that a lot of people in 12 steps are very vulnerable and they can be predated against. That's why there are women-only 12-step programs now, trans-only programs, because it should be on some level, because the dangers are just so big there. So no problem. Meditation, spirituality, cognitive tools, 12-step programs, all that's good. Do you recommend we refer out clients when who we are seeing in a specific setting, say domestic violence counseling, that we later find out are also engaging in self-harm? Meaning treating cutting may be out of our scope of competence, but in your opinion, should we refer out or try to consult and learn how to treat or work with these clients? If you're doing classic psychotherapy for battering or something, I think you can integrate this stuff, because among other things, I wouldn't want to overstate it, but models like Bowen's model in the University of British Columbia sees battering as a form of distress reduction behavior. I think it's a little more political social than that, but clearly we do find some people that do that. So you could say that this is all part of a piece and you could include all that in treatment. If it's a structured domestic violence treatment program or anger management course, there won't be a place for that. And then, yes, I think that if you believe that's a problem, referral might be a really good idea. Again, there's so much overlap here, though. A lot of anger management classes, I would rather they got this. And they even, anger management will include some of the themes that are in here, but but they're treating it and approaching it differently. I'm suggesting anyone in this room could benefit from some of this. Doesn't have to, and what needs to be done is a psychotherapy enterprise. The more you make it just a program that's more authoritarian and controlling, just the more likelihood that you won't be able to use these principles in that work. But I am all for referral. So for instance, when I teach on mindfulness, and I know that Randy in the back room does this as well, we say that it's okay for the average therapist to do a little mindfulness for their clients, but if the client really needs more mindfulness training, we recommend that be referred out and have someone else do that, because you have enough other things to do in your work, plus you may not know enough about the advanced aspects of teaching mindfulness to others. So good question. Okay, now you see the SBFR review. You know there's a manual to today. Do you have the manual? Do they know that it's on the web? Okay, so there is an actual manual just on what you're here for today too. So you should hear this as in this room, but also on the webcast part of it. If you go to the ITCTA website, there are manuals you can download for free there. And one of them is working with self-injurious behavior. And it's all the stuff we talked about here in a printed form. It also has all of the measures in it. And there are a number of measures, and we'll be hearing about them a little bit. This one, Self-Injurious Behaviors and Functions Review, specifically, I recommend you give that to the client when you start to work in this area with someone. What they do is they rank up to 18 different kinds of self-injurious behaviors, see all the different ways in which people can do things, pull their hair out, punch a wall, pick at your skin, rub or scrape your skin until it burns, bleeds, or makes a mark, intentionally breaking bones in your arms, legs, etc., which does happen. So what they do is for each of those behaviors, they rate the age they first did it, the age they last did it, and how much they've done it in several different categories there, in the last 6 months, in the last month, in the last week, and the last 24 hours. This is new to ITCTA, the approach that we generally use here for self-injurious behavior. So this is a new measure. I do think that you'll like it if you have enough self-injurious people, or if you have someone you're really worried about. Because let me tell you, this is what it's going to do. Almost everybody's not going to tell you all the ways they cut because they're embarrassed or hurt. They're already embarrassed enough they cut. They're not going to tell you they cut their genitals. They're not going to tell you that they poke their eye, or that they put lemon juice in their eyes, or that they're just not going to do that. But when they have a whole list, especially if you've already kind of depathologized this stuff, they can then list all these things in a way that's more helpful. And by the way, you will just generally find that the behavior section, the first column there, you'll get much more than, not much, you'll often get more than you expect. So you thought it was just cutting, but they're burning, they're punching, they're other kinds of things. Then the age, you really want to know about this. When was the first time they tried that? Is this something they're only doing now at age 15, or they've been doing this since they were age 3 or 4? Generally, that's a marker of chronicity and maybe severity. So the earlier that they first did it, the more that they've been doing this for a long time, the more it's probably attachment related. The last time they did it is a marker for just, is it still happening right now? Sometimes we'll say that they've done stuff, but they haven't done it for 3 months or 6 years. I would probably pay a little attention to that anyway, but I wouldn't overdo it if it's not happening for them now. But a classic thing might be, it started at 3 and I'm 16 and it's happening now. Then the question would be, how much is it happening over these time periods? So are they doing it a lot? Are they doing it a little bit? And very importantly, the last 2 categories there, have they done it in the last week? Have they done it in the last 24 hours? And then apropos what you've already been hearing about here, once they pick those things that they do, then, and why they basically do them, then have them rate how much they engaged in self-injurious behaviors to meet each of those needs, to distract yourself from the problem, feel control of your body, etc. And you can see there's a list of 37 different things that I found from the literature that we've used in previous tests of actual motivations why people might do things. For instance, if people have said things like, I cut myself to calm myself down, it's probably a little bit complicated, but if we could teach mindfulness to that person, they'd be doing something that's actually good for them instead of something that's bad for them. But we wouldn't know that that would work until we found out what were the functions that for them of engaging in the behavior. So these 2 things tend to give you a pretty good view of what behaviors are engaged in, how often they do it, and why do they do it. And I would recommend you do that in the first session or in the first few sessions. The argument against doing it too quickly is if they still are very embarrassed about what they do, they feel like you're asking them to confess to every bad thing they ever did by filling out this whole list. If you have questions about this, feel free to ask me more later. I'm just actually presenting them to you now.